Hi, and welcome to another video from the CTAD Clinic. My name's Dr. Mike Lloyd and I'm the Clinic Director. In today's video, we're going to be looking a little bit more about depersonalization. So this is one of the disorders that are mentioned in the DSM-5 and the ICD as part of the dissociative responses to trauma. And depersonalization can be defined by the DSM-5 as being an experience of unreality, detachment, or being an outside observer with regards to one's thoughts, feelings, sensation, body, or actions. And examples are given as perceptual alterations, a distorted sense of time, an unreal or absent self, emotional and or physical numbing. And the reason that we pay attention to this is because depersonalization is such an important response for people. Within dissociation, there's a lot of emphasis often on dissociative identity disorder, DID, and other specified dissociative disorder, OSDD. But actually, when you think about the nature of what dissociation actually is, in response to trauma, certainly in early childhood, depersonalization is one of the earliest responses of the defense system. It's one of the things that the person can achieve without having a conscious sense of self. So for infants and for children that are being hurt, depersonalization is an excellent response to whatever is going on to them without them having to have any conscious perception of what is going on. It also means that they don't realize what's happening, and the brain then builds the depersonalization as that defensive response very, very early on, which means that it can come back later on. If we think about how the body responds to shock or anxiety or fear, it tends to go back to those earliest, the most primal defense systems that it worked out. And in a dissociative system, depersonalization gets organized very early in childhood in children, and therefore can come back in childhood, in adolescence, in adulthood, middle and late, over and over again. So we see depersonalization occurring throughout the systems that people have within DID and OSDD, but it often gets overlooked. So therefore, what I wanted to look at today is the sort of difference between that chronic and the acute response. So when we think about those terms, they're really important. And this is the stuff that comes up time and time again in clinical practice, and certainly when we're doing the SCID-D, the Structured Clinical Interview for Dissociative Disorders, which is our diagnostic tool, and there's another video on that, that people describe having this sense of ever-present, of something being always there. So always is a really common response when we're looking at depersonalization questions within the structured interview. And what we mean by that then is chronic is something that is ever present. It's always there. It has been there for as long as the person can remember. And it's present in them at that moment in time. It's always been there. And without there being a sort of a way of being able to work with this, to process the trauma, to effectively heal the trauma, that depersonalization response may go on and on and on. That's what we mean by chronic. It's pretty much always there. It's going on and on and on. Acute is much more about that very intense, very sudden experience. It's often short-lived, it can be very unpleasant, it can be very uncomfortable, and it can be frequent. It can occur a lot, but it doesn't tend to last for a long time. And what a long time means is incredibly dependent on the individual. So for some people it could be 5 seconds, some people it could be 5 minutes, for some people it could be over an hour. So we have to look at both the chronic and the acute presentations of depersonalization. So it comes back to the essence of what Bessel van der Kolk was saying in his book, The Body Keeps the Score, which is this book. It's an excellent, excellent book. And the key component of that is that the traumatic experience, often located in childhood, is held within the body. So therefore, the body responds during traumatic re-experiencing or trigger effects later on in life. So the essence is that the trauma is located within the body, and the body has its own response. It has its own system of managing that, which is not within conscious organization. So you don't get to choose it. It happens for you, at you, without you. And that's really important to understand. If we think that you've got the trauma on one hand and the conscious self on another. So trauma's here, conscious self is there, and the body is the thing that is in the middle. It's trying to divide those two. Think also about like the polarity of magnets. If you have magnets with sort of both polarities within them and you try and put the same polarities together, they push apart. You can't push them together. So no matter what you do, the magnets separate from each other. It takes incredible force to hold those things together, but what they want to do is move away. And that's like the person and their traumatic experience. That's how we see it in therapy a lot of the time. That there's this either denial or this phobic response to the trauma. And what the body is doing is it's trying to manifest that, it's trying to make that happen. So as the person tries to get close to the trauma, the body responds by depersonalizing. It dissociates the person away. It removes them from their body. It removes them from the space because it's trying to avoid that traumatic response. It's trying to avoid the pain, the suffering that the body remembers from early on in childhood. And this can be done with the person as well. So if the person can detest their feelings, they can detest their trauma. They don't want to go anywhere near it. Anytime they try and do it, the body keeps them away. So in a way, the body is doing what the person wants to do, which is remove themselves from the trauma. But this isn't helpful because this is the chronic response. This is where it goes on and on and on, that there's this interplay, this dance between the person and their traumatic experience, and the body manifests that structure. It organizes things so that the person can't get close to the trauma. And even when they want to, the body is there to try and stop them doing it, because the body isn't really doing what the person wants to do. The body is doing what it feels it needs to do in order to protect the self. So the healing or the therapeutic response is what we look for. That's what we're trying to achieve, to bring the body and the person together, and in essence then bring the person and their traumatic experience together in a healing way. Not as a shock value, but as to heal them, to try and build that in. So you approach the trauma very carefully because you're aware that the body has this chronic response and it manifests that trauma in that physical sense. When we think of the acute response, that's much more about that immediate trigger. That's where that sort of fear, anxiety, that suddenness comes in. So the person is in a space, something happens within that space, and suddenly they're depersonalized. And suddenly they are shifted away from their body, and they have this sense, this description of being moved away, that the distance is greater, that they are somehow absent from their body. They're being pulled away from their body. They can see their body sitting there, and they are being moved further and further away from it. And that's that early traumatic defensive response that the body brought in when the person wasn't able to achieve anything. If we think about what the person is likely to do in a sudden, scary situation, our fight flight kicks in, get out, get away becomes the impulse. That's the thing that we really want to do. Get away, get away, get away as fast as you possibly can. But if you actually can't, if you're not mobile, if you're a child, very early infant, you cannot get away, or you're being held, then there's nothing you can do. So the get out, the get away becomes from the body, not from the situation, but from the body. So later on in life, when something suddenly scary happens, the impulse, get out, get away, occurs again, but in adulthood, and the person is dislocated, disconnected from their body, which shifts them away from that trauma. It's much more less helpful in adulthood, however, because often that situation isn't really going to be scary. It's a trigger, it's a simulation of something scary, but it likely isn't. Now, obviously, if it is a really scary response, that's a whole different thing. What we're talking about is triggers. So instead of being in an abusive environment, you're in a supermarket, something happens and suddenly you depersonalize. That's not particularly helpful because it's not going to get you your shopping done. It's going to make things really unpleasant for you. So we have to understand the nature of that acute response, and that can occur on top of the chronic responses, which makes depersonalization incredibly difficult because they never feel present in their body. And the bit that's really, really sad is they don't often want to be in their body. That the body was the target of abuse, the body was a target of traumatic experience of pain, of suffering, of fear, and they don't want to have anything to do with it. So there's often a hostile interplay between the person and the body. They don't like the body, they don't like themselves, they don't like their body. So the depersonalization is actually quite handy because it stops them connecting to their body. But we know therapeutically that that isn't going to bring about any healing. So to try and connect the person back into their body, to be present, to be connected and linked to the physical sense of self, is a therapeutic goal, and it's incredibly difficult, and people often resist this enormously, or they just don't know how to go about it. Often therapists get pretty good at working with parts within DID and OSDD, but not so good at working the depersonalization stuff, like I said at the start, because it's often an unknown. It's a bit of a variable that sits in the background. Somatic therapists are really good at working with the body, and there's loads of techniques and loads of approaches therapeutically to work with the body to both limit this chronic response and this acute response. The goal always with dissociation is to bring the two together gently, patiently and carefully, compassionately, and to allow the person to have that sense of being connected with that body, to feel safe, to feel present. That's what we're trying to achieve. And we have to do it with both the chronic, long-lasting, and the acute, sudden impact type shock value. So I hope this has been helpful. I hope this has given you a bit of an understanding. Depersonalization is well worth looking into because it's just there in the background. It's, again, I use this analogy of the mobile phone type stuff, that it's the depersonalization for many people is like an app that runs in the background all the time. They're never really connected. That is constantly on the go. And then they have these sudden spikes where the acute response kicks in. So what we do is we try and manifest a therapeutic situation to allow the person to be connected to their body. It's very difficult, but it is extremely worthwhile, and it can really enhance the quality of life of that person. Please do like and subscribe for further content. We'll continue producing videos. Please leave comments in the video section. And as a little extra, I think this is our 49th proper video. And our next video, number 50, is going to be something a little bit different. So please have a look at the community section for a hint about what that is going to be. And I hope that the next video is really good for you. So in the meantime, between now and the 50th one, please do take great care.